We're now going to do something a bit different, and we're going to have a patient survivorship panel led by Dr. Tim Pearman and Heidi Ray. Tim Pearman is a board-certified clinical health psychologist, and he specializes in psycho-oncology. He served in clinical, administrative, and research roles in academic medical centers throughout his career. Dr. Pearman is a professor in medical social sciences and psychiatry and behavioral sciences at Northwestern University, Feinberg School of Medicine, and he's the director of supportive oncology at the Lurie Cancer Center. Thank you.
Well, everybody can kind of take your seats if you'd like. Congratulations to everybody who made it to the end of the day. We greatly appreciate it. This is the last, but definitely not the least, of the presentations. I think you all will be really, really pleased that you stuck it out until the end of the day. We have an outstanding panel today, and I think that this is a really interesting way of allowing both the clinicians in the audience and also the researchers in the audience to have a little bit of a discussion with patients and providers who've been involved in survivorship on the front lines of this, to really talk about kind of how some of the innovative research that you've seen presented today, how that plays out on the front lines in terms of clinical care, if at all, because in some cases I think it really doesn't. So this will be a really good opportunity, I think. The way that I'm hoping to run this is to have each of our three panelists spend about 5 minutes just kind of introducing themselves to you and talking a little bit about their experience in cancer survivorship. And then after that, we'll open it up for discussion and kind of see where things go. As Chris said, I'm the director of the supportive oncology program here at Northwestern and at Lurie at the Cancer Center. And we're really lucky here in that our supportive oncology program is pretty broad. So we have psychiatry, psychology, social work, dietitians, patient navigation, patient education, tobacco cessation. And then we also work really closely with our colleagues in palliative medicine and rehabilitation and integrative medicine. And I'm looking at David Victorson. By the way, isn't David Victorson the coolest person? I want to be as cool as David Victorson when I grow up. But at any rate, so that's kind of our program here. And so we can certainly talk a little bit about what some of the supportive interventions are that are available to our cancer survivors, but realizing that in a lot of non-academic medical centers, you may not have access to all of the same services that we have here. So we can certainly talk about that a little bit as well. So I don't know who wants to start.
Sure, I'll start, but I'm not going to take 5 minutes. So my name is Heidi Ray. I have been an oncology nurse for 38 years now. I have worked at Northwestern that whole time, started inpatient, and now have moved outpatient. When I was a new nurse, I'm going to date myself, in early 80s, I just turned 60, we didn't talk about survivorship. We treated patients and patients went home. And now I see survivorship totally different. I see survivorship actually in 3 different ways. First, patients have learned and accepted their diagnosis, so they're able to then move on to the next step. I then see patients completing treatment as another form of survivorship. And then I see the life after treatment. How are they doing post-treatment? How are they dealing with their life now that they've had continuous care and they're out in the big world alone? I see survivorship as a team approach. I am so lucky here at Northwestern because we have so many different things available. Social work, like Tim just said, PT, OT, psychologist. We use American Cancer Society all the time. We have Gilda's Club representatives here in the Cancer Center. We use Wellness House. We have brochures from all over for suburban patients. Indiana, Wisconsin, we have everything available. My phenomenal social worker is sitting in the back of the room, and all I do is go to her office and say, "Can you help me?" And she does. She introduces herself to the patient, finds out exactly what they need. I mean, I couldn't imagine it. We did not have this years ago. So I I really feel like we're blessed. We give patients what they need. We give family members what they need, because patients aren't in it alone. Those support people need to be taken care of also. So I just think we're so lucky, and we stress to our patients, even though you're finished with treatment, you're not alone. You still have us for as long as you need us, because your side effects will continue. Your anxiety of your cancer returning will always be there. You may be depressed. You may not be able to carry on all those activities of daily living that you did before, but we are always there for you. And you know, people say, how can you work with cancer patients and for that long? You know what? I'm blessed. I am excited to go to work every day, even though it's only with my cancer population. I don't look at it as only, because I feel like I'm a team player and I'm helping somebody every day. So thank you all. This has been a wonderful day.
Hello, I'm Jennifer Carrera. I'm the new adolescent and young adult oncology navigator, but I think Tim wanted me to speak about my survivorship today. So I'm also a young adult cancer survivor. I was 25, living in Chicago, living in the big city, dating, traveling, dancing, getting ready to go to graduate school, and I found a lump, which I decided was a stress knot because of all the stress of being single and dating and dancing and going to shows. So I lost weight. I all of a sudden couldn't have the stamina to shop, so I went straight to the doctor. And they told me I had stage 3B Hodgkin's lymphoma with bulky disease, nodular sclerosing. I got 3 opinions, and I chose the most because more is better. So I had 8 rounds of ABVD MOP and a month of radiation. So I've had pretty much every long-term side effect you could imagine. My treatment was delayed a little bit. I had some excruciating pain due to Neupogen that put me in the hospital. And then I also developed avascular necrosis towards the end, and my hip cracked when I was climbing Red Rocks in Colorado. All that time I did work the entire time except for those 2 episodes. And then my long-term side effects started, like I said, towards the end. I had to write down my long-term side effects because there's a lot of them. So since then, I've been dealing with AVN in my hips, shoulders, and knees. I've had 3 left hip surgeries, 2 right hip replacements, 2 left hip replacements, a right shoulder replacement, chronic pain, peripheral neuropathy in my hands and feet, hypothyroidism, premature ovarian failure, and infertility. And when you're 25 and they say you might go through menopause, you can't have kids, you don't realize that that means you're gonna have hot flashes. So I started having hot flashes and thought my cancer was back. So definitely need to do a better job of educating there. I had radiation-induced vessel disease and had a heart attack at 38 and had a stent placed, radiation-induced pulmonary fibrosis, skin cancer, and then a fun fungal infection up in my sinuses because nobody told me I shouldn't inhale when I was going through treatment that they had to scrape out, and financial toxicity. In the end, thank God for Bill Clinton, who signed in the Portability Act, I was able to quit my job and go back to school, and me and my pre-existing condition, and got my MSW and fell into oncology, and here I am. So.
Hopefully this is loud enough. I'm Craig Cox. I've essentially had 2 periods of detection, treatment, and survivorship. 20 years ago, my doctor said, I went to my doctor, I said, I'm going to the bathroom in the middle of the night, what's wrong? And he said, oh, and then we'll test. And then he said, you have prostate cancer. What do you do when you hear you have cancer? Get rid of it, I don't want it at all. So I got rid of it. Then 4 years ago, the PSA levels started coming up, and I went through ADT treatment and radiation treatment, and I'm here now. Okay, they're different though. The survivorships are totally different. The first survivorship, I was incontinent for a little bit, which was distressing. I mean, you don't want to wet your pants or something like that if you're wearing white trousers during the summertime. But that left. But I was also wildly dysfunctional sexually. I couldn't get an erection. Nobody tells you about this. The doctors say, oh, we're going to do this special nerve-sparing thing. It'll be just like it was right now. It's not at all. I've never heard anybody that it's just like it was before. So you're married, you go through, you think, it's got to be me. I've got a problem. Your wife thinks it's got to be her. She's got a problem. And being hyper-educated World War II children, you of course don't talk about that because it's not nice. So life continued, but there was this elephant in the room of this sexual problem. There's nothing to read about it, nothing to talk about it. You'd go to the doctor, well, I did nerve-sparing surgery, or have you tried Cialis? Well, and you get isolated. You don't talk to anybody about it. Nobody wants to, back then, nobody wanted to talk about cancer. They'd say, oh, what did you have? Oh, well, I had a prostatectomy, I had cancer. Oh. I mean, I might as well have said, I have hemorrhoids. They just didn't want to talk about it at all. So I became extremely isolated. Children, everything functioned well, but I was still isolated because there's this thing, what's wrong with our relationship? And then my wife died unexpectedly. And right at the same time, my PSA levels started to multiply. And my urologist said, oh, well, don't worry, it's not time for a Hail Mary, but I'm looking at this thing and it's going bigger and bigger and bigger. I didn't realize cancer came back. I'm educated, but I'm so stupid. And so I finally had something done about it. ADT in conjunction with radiation. And the radiation ended in April of this year. Survivorship, it's totally different. I've gained 20 pounds. I have no muscle strength. My bones are deteriorating rapidly. I'm tired all the time, but I feel so much better. And why do I feel better? Because I'm not isolated anymore. I'm a lay person on a SPORE panel here on prostate cancer. That's sort of getting me out of my isolation. I'm actively going to meetings of us too, prostate cancer group. And I started trying to help others. I would hear at my church that somebody had been in the hospital with a prostate cancer operation. And so I'd ask the minister, do you think I can talk to him? The minister would say, oh, I don't know whether he'll want to talk about it or not. Well, 50% of them don't. But I go ahead and I try to ask them. But the other 50%, they're really eager to talk about it. Well, who did you go to and what did they happen? What are the after effects? And that's a wonderful way to get rid of isolation, talking to others, and it should be totally encouraged. It's so different right now, and I actively try to help others. I belong to a group called The Village, which is 450 seniors. I just got off the board and executive committee. I'm still active, trying to promote health awareness so that members don't go to the doctor the same way they go to the car mechanic and say, oh, do anything you want to. I am active in my church. I am trying to work with an app that I heard about here last Saturday that I want to do a beta testing on so that people can take control of their health. Now, what are the takeaways that I would suggest that you follow up with? A, don't tell anybody that, oh, it's going to be nerve sparing, so there'll be no problem at all. Obviously, if you tell them the whole truth, they're not going to, not me. But they've got to know the truth. Otherwise, they don't know what's happened to them. The second thing is there's an organization statewide called Us Too, which is a men's prostate cancer group. And if you're not close enough to a meeting, people can go to their website. It's very useful. It kills the isolation because you hear what other people's experiences are. And thirdly, keep a friendly, warm environment in your institutions, no matter where they are. As an example, radiation oncology at Northwestern under Dr. Kalapurikal or Dr. K is just an ideal thing. You go in there, everybody is smiling behind the desk. They don't say, oh, go back there, you're standing in the wrong place. They say, oh, we're so glad you're here. They try to remember your name. The technicians are good. There's something really frightening about going into radiation, lying down on a bed and having a machine whirl about you for 5 minutes and do this every weekday for 2 months with a full bladder because they've got to position your organs. Well, it's not only a full bladder, it's a bladder full to the bursting point. And so the machine's going and you're going, hurry up, hurry up. And of course, the disaster will occur once or twice. And instead of saying, oh, you shouldn't have done that, it's very embarrassing. Then they say, oh, well, you know, you haven't done that yet, and everybody does it. We were waiting for when you do it. And then they laugh and they clean it up. And it was just ideal because all the personnel were friendly and concerned and caring. And that is so helpful. They were also good and they knew what they were doing, but even if they didn't, I wouldn't have minded going there. They were friendly. But that is just a major, major thing for the patient to go through something frightening with a friendly environment and friendly people, to know in advance what's going to happen, like nerve sparing is a joke. And thirdly, to put them in touch with other people that they will talk to in a similar situation. And I think that's surefire success for any patient, just those 3 things, which are practiced here at Northwestern. It's wonderful. Thank you.
Thank you very much to all of you for kind of sharing your story. We can open it up for questions, discussion. So, yeah, Lisa. So I'll try to repeat the question for any of you who couldn't hear it. The question was basically, in some of these groups like Us Too, or some of these, like, patient support groups, or however you want to describe them, you can run up against situations where one patient's had a terrible experience with Dr. Smith and says, like, don't ever go to Dr. Smith and don't ever let him or her do surgery on you or whatever it is. And the question was kind of what do you do with that as a cancer survivor when you're in one of those groups?
It does happen all the time. My favorite doctor, you might say, my God, he's a butcher. But if you look at it, it's like Thanksgiving or Christmas family dinner. Some people are going to like one thing, some people are going to dislike something else or another person. And you just have to, somebody will say, oh, I'm never going to go through radiation. I'm eating Brussels sprouts. That will take care of it. Well, you just smile and say, oh, well, that's fine. I didn't go there for advice. I went there for camaraderie, to be with people that were sharing my experience. And for advice, I go to my physician and say, have you thought about the Brussels sprout diet?
The other thing I can just comment on as a psychologist who's led some of these support groups is one of the rules that I always have had whenever I'm in a group setting like this is we can talk about the experiences we've had, but not to mention names. So that's always been like one of the sacrosanct rules, like that and confidentiality are kind of the two biggest rules in any group that I lead. Is you can talk about the experience, talk about how horrible it was, talk about how bad your physician was, but not to mention names, because someone else, like John was saying, it is like a family dinner. You know, some people just have different experiences with different providers. Yeah, Sheetha.
This question is probably either for Jenna or John, but we talk a lot about just like all the services we have, especially here at Northwestern. And Jenna, you have a really interesting perspective now of offering it to patients. But from your perspective at least, and I know everyone will have a different opinion, of how as a patient do you want to know about these things? I think we do sometimes a not so great job of like patients even knowing about what we can offer. But then on the other side of the coin, I worry that I just like give them their diagnosis and all the treatment, and then I'm like, and here's what we offer. And then their head explodes. So is there something that we could, from our perspective, kind of learn from when and when to offer this stuff?
I would think that it would probably break down into finite pieces. What after effects will I have? Will I have any pain after the surgery? Is the medicine going to be awful? Will it cause my hair to fall out? But if you break it into little things like that, rather than sounding like your rote message, listen silently while I read this aloud, I think that helps. And looking them in the face and establishing a one-on-one contact with them, rather than doing the computer while you're talking to them. That's really important, because it's me. It's not that. And if there's not that feeling of rapport, I leave and I'll change, which I have in the past.
I also, like, if I can throw in something related to this, while you guys were talking, I actually wrote down, how did your providers describe the longer term and the late effects, if at all? And if, like, how would you like them to do that?
I wanted to know everything like 20 years ahead. I mean, I read my entire chart. I'm like, what is this? I'm depressed. I'm not depressed, you know? So I like the information, but you need to be reminded along the way. So when I became infertile, because I did get menstruation for a while, they're like, well, we told you that could happen, you know? And it's like, I didn't know I was going to go through menopause and the hormones and all of that. It's a whole different world, you know, going through menopause. So I believe in giving all the information. But on the professional side, I have a packet for my young adults, but I don't just say, here's all the resources. I do a comprehensive assessment with them and try to decide, okay, wow, I think True North Treks would be really, really good for you, given that you like nature. You really don't want to go to a support group, but, and I tailor it towards them, and then I'll make it succinct for them. So I'm biased in giving them more than less, but you may need to reiterate and re-educate and remind along the way.
Yeah.
Yeah, I agree with that. My brother-in-law did the same thing where he was given a hopeful promise of a nerve-sparing radical prostatectomy, and it didn't happen. He was offered injections afterward, which he wasn't interested in that, So, yeah, you do your best, but nothing's absolute.
I mean, that's a very big thing, and it's really important. In the same way fertility is important, and if somebody glosses it over and says, well, it doesn't happen to most people, or you've got to be prepared for it. I mean, I was just in the dark after my prostatectomy and isolated. I mean, I functioned socially, but I was really isolated. I didn't talk to anybody about it. It was not a happy 17, 18 years. And I think that was because my provider probably didn't know enough about the thing to tell people about it then, but that was back in the dark ages, and people know right now. And you should tell and not sugarcoat it. You're gonna have 7 children running around, baloney. Who wants to hear that? I want to know the truth. And it would have been nice to know that my cancer was going to return. I didn't know that cancer returned. I was stupid, I think.
Yeah.
If I could build off of something that Jenna said, we have a program with our support services, and we meet everybody in the beginning, and we, each one of our teammates, we tell them about some of our programming and exercise, support groups, nutrition. How often do you want to, how often do you want to be reminded? Because we struggle with that. If we tell them at the beginning of treatment, then we tell them at the end of treatment. So okay, it's been a couple months. Are we going to tell you again at your 3-month checkup? Are we going to, where is that limit, or is there not a limit that you want to be? Because we know those needs come up at any time, right?
Yeah, it's a delicate art, I think, but you don't want to nag them or harass them, but gently somehow remind them that that might help with a certain issue. I mean, I usually 3 strikes and you're done, I don't want to bother them again, Yeah. So, and disclosure, like you said, related to the fertility. So they told me up front, even way back in the dark ages, that I probably would lose my fertility. But that was good because that started the grief process then. And then when it actually happened, I was sort of prepared.
Yeah. Anne Marie.
Yeah, thank you so much for sharing all of your stories. I started I was the first here this morning, and one of the things that I said was I specialize in cancer rehab. And when I see a patient, a patient with cancer-related impairment, I almost never have a patient with one impairment. In general, your case, oh yeah, I see you. I do. I mean, I have to but lots of patients have similar experiences. So what are your experiences, both of you, with rehab services? And what could we do to improve that or forfeit this
In case anybody didn't hear that, the question was, what have our patient panelists' involvement with rehab been, and how could we make that more accessible or available?
I've been involved in rehab since I was 25 due to the replacements and surgeries, and my first physical therapist was the greatest physical therapist ever. One day I came in and I just was crying, and all we did was he just sat there with me and got me a Coke, and we just sat there for an hour, and listened. And so it was extremely therapeutic. But no, I believe in physical exercise. It's the only way to recuperate. And I'm not exactly sure what your question was, though, about rehab. I mean, I value it. Yeah.
But, what are some ways that we could, like you said, make it more accessible, improve on it? What sorts of things could we latch onto it, like physical activity programs?
Yeah, it helps if your providers refer to you. I think that's important because not all of my providers believed in it, including my shoulder guy, which I thought was kind of crazy. But yeah, I don't know. Do you have any ideas on that?
Yeah, even in a big place like this, physical rehab is some of it is extremely good, and the people are very good at doing it. But if you look like you're in reasonably good shape, like I look, but I'm not, they say, oh, you don't need it, or something. So I, as a patient, have had to go out and seek physical rehab through Northwestern and through the Shirley Ryan. And it's been a difficult process. I don't know whether there's so many things, you've got urologists, radiation oncologists, and oncologists, this and that. Maybe there's so many that it's hard for them to connect and see what a problem is. But it's a major thing, and it should be easier in smaller institutions where you don't have the plethora of people. But I think it's important, and I think that if you've got to insist for the patient, because the patient doesn't know where to find it. The patient becomes expert after a year and a half of it, but before that, you've got to help them and say, look, physical therapy would help you. For the months of radiation, because they didn't want to switch the internal organs, I was told, don't exercise at all, which was deadly.
And I think OT is under-prescribed for sure. I mean, they're very holistic, and I think there's a lot of things they could refer to OT for that they don't.
Yeah.
So Tim, I'm gonna try to save you from actually repeating it again, mainly because I can, for obvious reasons. So, my question is for all three of you all. I'm very interested in social determinants of health and their role as they're associated with disease management. And so for Heidi and Jenna, what are ways in which you address those? And even John, what are ways in which your providers have addressed those? Namely, I've heard a lot about maybe language barriers or addressing other cultures so far, but not really a lot as far as, forgive me if I missed it earlier, but not so much as far as like, well, do you have the ability to come back for follow-up care over and over again? Do you need that transportation? Do you need the bus pass? Do we talk about conversations as far as, well, how far does it take for you to drive and are you able to get here? Do you have the ability within your neighborhood to do the physical activity? So what are those determinants, ways in which you address those determinants of health, including health literacy, including income, so forth, in your conversations to make sure survivorship care is possible?
I'm quick. No one did that to me whatsoever because I don't look obese, and so they don't think that. But radiation oncology under Dr. Kalapurikal, the first time I went there, they had a social worker assigned, and the social worker asked what I was doing, she got $300 worth of CTA passes sent to me from the American Cancer Society because that was how I was going to get down there or not. she also said, I don't know whether you need to talk to somebody about this or not, but if you do, I would suggest that you talk to Dr. Pearman. Do you want me to make an appointment? They were terrific, but it was only at Radiation Oncology they did this.
I can talk a little bit about from my clinic. So prior to beginning any chemotherapy, we have a very detailed chemotherapy teaching session with one of our nurse practitioners with the patient one-on-one. At that particular time, they go over all the possible side effects, and as many of us know, there's a lot of possible side effects, but in the process, we'll discuss that on site, if something comes up, that you think of something at home, or if while you're here, you would like to meet with different people. Like I said earlier, Katie, who's sitting right back there, is available. She can discuss transportation. She can review different options from drug companies. She can meet with you, send you to different people. We can talk about different services. We as nurses do a lot of our own referrals, sometimes without the provider, if we notice that physical therapy is needed, or OT is needed, or home care is needed. There's a lot of parts of the patient that we have to treat. A lot of the education is to a lower grade level so that everyone understands what you're actually being taught. You know, simple words so that you can ask the question so that things aren't, you know, educationally above. We have different translators available that we can call and do over the phone. We have we call it Wally. I don't know what you all use, but you know, that you can bring into the patient room if English is not the first language. But I think as health professionals, we need to make sure that we treat the whole patient, because when you're diagnosed with cancer, and I have never been diagnosed with cancer, but I couldn't imagine it. I'd be afraid with the diagnosis alone, so maybe I'm not going to hear things. So I think it's important that we re-educate or readdress with the office visits that they come in, whether it's a lab appointment, a provider being an NP or an MD or an infusion appointment, that we make sure that the patients are receiving the different pieces to the puzzle that they need.
Well, I hate to have to stop the discussion, but we are out of time. I want to thank our panelists very much for sharing their stories. And thank you, everyone in the audience, for facilitating this discussion as well. I think it's been really good. And I'll call Chris back up.